Okay, everybody, welcome to this Lent series lectures. It will be today about urban health. I'm Hans Orru, I'm professor of environmental health. I'm from University of Tartu. And today we will have 3 short lectures. First, I will give some input to the topic, telling about different urban transportation modes, how do they affect our health, bit on air pollution, noise, also active commuting. Then we have other lectures more specifically on different urban environmental determinants. Ainhoa Beres-Urtoa, she's from Basque Country, and she is will be probably soon PhD student, and she will present her study protocol. Then we have Robin van de Castell. He's from Kent University, and he will talk about ethnic discrimination and cultural sensitivities, also related to different problems in urban areas. So they are like a bit different topics, but all the common ground is still urban health. And you know, currently more people live in urban areas than in rural areas. If you come to Europe, though, it's more than 70% are living in urban areas. So in a way, that's very important indeed in environmental health. Before that, we have told that we will be touch on urban health, but there is also connection on One Health. And I think for readers and people who are listening us would be good to know what do those mean. So environmental health is how environmental factors affect our health. Also the human health is the center. And then we have a nature processes. And you know, this human health is in the center of that. We have different factors from different health determinants. But if we come to the urban health, actually, we should take all this into account and also social factors. So if we come to these inequalities, different social problems in urban areas, it's not only environment actually that affects our health. So if we take this kind of statistics, basic statistics on the health, often people in urban areas have a better health. If we just take life expectancy, some kind of disease patterns, it might be even better. So we have to go into more detail to see what are the factors, all the factors that affect our health. So we know indeed this urban health is very complicated issue, how to improve this. So it's not only taking away those factors, I will talk in a minute. So one important part is our transportation modes. So because, you know, air pollution comes largely from the cars, because we don't have factories in urban areas. So also noise comes in large extent for the transportation. So it depends what kind of mode we have been taking. And let's take just half a minute and think about how did I come to office today? What kind of transportation mode I had? Okay. Why I did take this transportation mode? So was I thinking something else? So because there are different options available. So there are good sides, bad sides of this. So if we just take purely statistics, like in my towns, most of people, and also in my institute department, most of people take private car. Even we are working in Institute of Family Medicine and Public Health. So, but more than 90% actually are taking private cars. Why? It's because it's easy. So if you are in a larger kind of city, then it might be more complicated, but in smaller cities, it's quite easy. Bit better would be if there is a ride sharing, you are not coming alone, you take a friend with, or we have a kind of different sharing kind of things available nowadays. Public transportation, that's even better. Light traffic, I usually take light traffic, and because that's quickest, it's very easy for me. But it's even better if people just walk. So how to get people more walk using light traffic, that's a challenge in nowadays world. So I thought about these different factors. So just a bit more detail, active transportation and how we could improve those things. So regarding air pollution, there are different pollutants. So I'm quite sure that those names doesn't mean you a lot. But one of the things to remember is often we think it's just respiratory disease, but it's not. So actually, so cardiovascular diseases, cancer, birth defect, cognitive decline, different neurodegenerative diseases. That's kind of spreading really quickly because people live longer. They have a lifelong exposures. So diabetes, arthritis, liver diseases. So in a way, because air pollution goes all the way to every cell you have, because some of the particles, as you see on the left side, are extremely small, so just a few nanometers. And then they have we call it also systematic effects. Another thing, it's not the only traffic exhaust that comes from the engine, but also more important nowadays gets road dust, because cars have got much cleaner. If we come to the electric cars, so they have very low emissions, but still they have emissions of road dust. And if you take this Tesla X on a picture, so if we take a road dust, this car has almost zero exhaust emissions in cities, but it has quite high road emissions because the cars are getting heavier. Cars are getting bigger, but also the battery weights. And if we take this Tesla X, it's 1 ton larger than Legora car. And that takes extra pressure on the road, and that's why the road emissions are increasing. So this kind of relative importance of the road dust is increasing in urban areas. How to improve the situation? So actually the smaller cars are better. So if we take minis and smarts and etc., because you in a way use less resources for the production, so they consume less fuel, and though there is also less kind of air pollution coming out of this. But what happens often if you go to buy a new car, so the seller tells you the bigger car doesn't consume less or more fuel than your previous car. And we have a trend that people are buying larger and larger cars. And so this fuel consumption is not decreasing. It stays quite the same level. Electric cars, as I tell you, so we have a tightening of emissions. So we currently have Euro 6, but Euro 7 is on the way. So different taxis have different countries. So in London, in Stockholm, there is a congestion charging that in a really center of the city, you have to pay, and in London quite a lot. Or there is even low emission zones or ultra low emission zones. That means only the least polluting cars can drive in the city centers. What also can be done is better urban planning, because a greenery absorbs air pollution. And another important side is dispersion conditions. So how we put the houses, where are the parks, that depends how well the pollutants disperse. And this must be as good as possible. We have had also studies showing that not all the things go worse, but actually their quality has improved. And that's an example from Stockholm, where we could show that because of the better air quality, people live at least a year longer than they used to. And then can be also seen in statistics because the life expectancy is increasing. So some information regarding noise. So it's a European-wide problem. So let's say every fourth of person are exposed to high noise levels. So that makes annoyance. People cannot sleep disturbance, health impact, and the one way that can also cause chronic disease and premature death. In cities, we have those kind of noise maps that's coming from the EU regulations. So left side, it's the capital of Estonia, that's Tallinn, and right side, it's Tartu, where I live. And if you take this map, even this light green is already the levels where the levels are too high. So in a way, it's the same also in Estonia that almost half of the population are living in too high noise level areas. So how this could be improved? Because that's also causing several hundreds of the chronic diseases we have had in some risk assessments and quite many premature mortalities. Less traffic, less noise. So more silent cars, better road surface materials. So what can also prohibit it is heavy traffic near the residential building. We have recently started discussions on reducing the speed limits. So if currently there is a 50 kind of limit in general in Estonia, this could be reduced easily to 30. Better insulation, noise barriers, but also some of the simple measures like tires. And this is labor from the tire. And with the current regulations, it also has to show what are the noise levels. And on the bottom side, you can see, so that tells you those tires make 69 decibels. And if you go to the store, you can have different labels like a 69 versus 72. This doesn't kind of sound big difference, but noise is measured with logarithmic scale. And every 3 decibel difference, that makes 2 times difference. So in a way, you can buy quite easily tires that are 2 times or even 4 times more silent than the other ones. Often people just don't know this. And that makes big difference in if you go to urban areas. And then in one study, we also had scenarios. So if these speed limits would be reduced, so actually the noise would be reduced by 17%, this kind of risk analysis. So we can expect up to 20% of effect if we make those kind of changes in urban areas. Lastly, active commuting. So I think everybody has done sometimes some sports. And it's good for our weight, our muscles. It prevents chronic diseases, boosts immune system, so releases stress. So there are quite good sides on that if we are having active commuting. So this has been improved also in large number of epidemiological studies. So this is a meta-analysis of my colleague from Umeå University, Asif Raza, made a couple of years ago, where he kind of looked for different studies. It's good for mercury infection, for a stroke, cardiovascular disease, different ones, diabetes, cancers, etc. So there are kind of quite many benefits if we are commuting more. And in some analysis in Estonia, we have seen the transportation modes also in cities. So even if we take just public transportation, we are not kind of telling that, okay, people, you have to change from car to just walk, but from the car public transportation, even those 2 minutes going to the bus stop, that's already active commuting, or taking a train. So even those small steps, that would be kind of large improvement in public health. So if we take the whole community we have in a cities. That's from again from Stockholm in Sweden. They have worked quite a lot on those issues, and they have mapped what are the possibilities and probabilities for a modal shift. Personally, I think this 30-minute bike ride, that's very optimistic, because usually I take less than 10 minutes and I'm not sweating, but if it's 20 minutes, I would be really sweating, and not very many people are ready to bike such long distances. But still, even if you take a smaller kind of amount of minutes, 10 minutes, 20 minutes, quite many places are accessible. It's just a kind of way of thinking. Even in Oulu, for instance, in northern Finland, so they have said that it's even bikeable during the winter time. So it's snow is not a problem. You just must have a different type of tires, different type of clothing, and then you can do it. And that's all from my side. I'm from Nordic country. I also put the cross-country skiing picture here. That's another type of active commuting. And even if it's a small city, we have a kind of cross-country skiing track even in urban areas. So thank you for this. And now let's go to other lectures. I think I will stop sharing, and maybe later we have some questions as well. So, Anhua, please, it's your turn. Sorry, you are muted. Can you please put your voice on?
Sorry. Hi again. Hello, everyone. And so in this short presentation, I'll be talking about a new project. To be more specific, about the study protocol of a new project that we have just started in 2023 and will last 3 years until 2026. This project is about urban environmental determinants of health, and it consists of a cross-sectional multicentric project based on population health service in Spain. So as you can see on the slide, I'll start first shortly explaining who we are, explaining the research group and the main research areas that we are working on. And then I'll go straight to the main point, which I think is the most interesting, and I'll explain the DAS-EP project, going through all the following 4 sections of the background, aims, methodology, and a short discussion afterwards. So to start, the research team, our research team is a collaboration between 2 institutes and 2 research groups. On the one hand, we have the Environmental Epidemiology and Child Development group from the Biodonostia Health Research Institute. On the other hand, we have the Basque Environmental Health Research group from the University of the Basque Country. These 2 groups, they've been working together and collaborating for many years now in projects related to environmental health. And among many projects that we are working on, we are mainly focused on the assessment of the physical and chemical environmental factors and their effect on health, as well as on the socio-demographic factors that influence during pregnancy and the child development. Also highlight that we are participating in the INMA project, which is a large multi-cohort study in Spain. So going to the point, as I said before, the DAS-EP project will be running from 2023 until 2026, and it was funded by the Instituto de Salud Carlos III with the Health Research Fund in the call 2022. And within our research team, 4 researchers will be involved in this project: Aitana Lerchundi, a professor at the University of the Basque Country and a research group leader from the Basque Environmental Health Research Group, and she's the PI of the project. Then we have Miquel Suiza Perez. He is a doctor in psychology, and he is currently doing a postdoctoral stay at the University of Bradford. Then Gonzalo Garcia, who is a highly experienced statistician, and then myself, who sooner than later I'll start my PhD project related to this study. Well, so as Hans has mentioned before, urban health. So what's urban health, and why is this important? So a report from the European Environment Agency reported or showed that in 2021, 75% of the European population was living in urban areas. And even more, they showed that this will have an increasing trend, reaching out 80% of the European population living in urban areas by 2050. We all know that living in urban areas and living in the cities provides citizens with many positive things, like many facilities, public health services, and etc. But we may not forget that the urban areas also bring together many environmental health hazards. And considering the high percentage of population living in these urban areas, there is no doubt that the urban health is a topic of high concern in relation to public health. And also, it's important to note that urban health goes far beyond the sole environmental health hazards, because as Hans brought to attention before, social factors also play a really important role in the urban health. Because of this, is crucial to investigate the combination of vulnerability, exposure, and of these environmental health hazards when analyzing the impact on health of the urban health. So taking and considering all this, after saying this, for this specific project, we created this conceptual framework. For some of you, it may look at first sight a bit complex with many arrows and going up and down, but at the end is what it is. Urban health, I guess, it's as complex as interesting. But basically what we want to represent in this figure is that in this specific project, we're gonna analyze the urban environmental exposures and their association with several health outcomes. And then we're gonna go a step further and we're gonna calculate or estimate the health impact at population level of those exposures. And why we want to do this? Well, because if we estimate the health impact at population level, then we are able to create urban indicators which can guide the policymakers to develop interventions that can actually improve the urban environment and improve the health of the citizens. Yeah, in line with what I said before, in the study, we're gonna also take into account the vulnerability of the individuals. So we're gonna adjust and take into account the age and socioeconomic status. And also I wanna highlight that we're gonna include both objective and subjective exposures. And the literature has shown that the perception of the environment, so not only the objective attributes, but also how you perceive your environment, influences and has an impact on the association between the urban environment and health. So it's very important to also take these subjective exposures into account. Well, after saying this, in this project, we created, or we have 5 main goals. First, we are going to estimate and describe the levels of urban environmental exposures. Then we are going to describe the urban environmental inequalities. Next, we're going to estimate the association between urban environmental exposures and several health outcomes under study. Fourth, we're going to estimate the impact of these exposures, as I said before. And finally, we're going to go deeper and try to assess the mediating role of several factors, such as physical activity, social cohesion, air pollution and noise on the association between urban environmental exposures and the health. Well, and how we are gonna do that. So as the title of the project indicates, this is a multicentric project in Spain, and is based on cross-sectional data from 4 different study areas. These study areas are the autonomous community of the Basque Country, Andalusia, Valencia, and the city of Barcelona. For the project, we're gonna use participants from the population health service that are carried out in these study areas. Just to make a short note, the population health service are official statistical activities that are carried out in these study areas every 4 years. So for this study, we're gonna take advantage and use this secondary data. We are expecting to have 17,000 participants as subject in the project. Then other point is that apart from this data from the population health service, we're gonna also include his estimates. But I'm gonna be talking about this second type of data later on. Well, here you can see the summary of the data collection and cleaning of the data for this project. On the left hand, you can see that there are 3 main parties involved, and yeah, there are 6 main steps. Now I'm going to go through all of them one by one. Well, so the first step is to collect data from the population health service from the 4 study areas. And now you can see all the variables that we were going to collect through this population health service, from the health outcomes such as general and mental health, sleep, consumption of medication for common mental disorders, prevalence of chronic mental health problems. Then we will also collect subjective urban environmental exposures, potential mediators, and also many covariates, both individual level and area level variables. Well, the second step will be to harmonize this data, because we are using population health service from 4 different areas. And it may, I must say that most of the variables are collected in a similar way, better say in the same way. But there are few variables that need to be harmonized. So now we are in this step of making sure that all the data from the different study areas can be compared and can be linked together. Okay, after that, we need to geo-referentiate the participants. So we need the geocodes of the home households of each participant. And why we need this? Well, because we want to estimate the urban environmental exposures of each individual at their household level. And the responsible for doing these estimations will be an external company, and they'll use his system, which is the geographic information system. Using this methodology, we're going to be able to have information on objective urban environmental exposures, including surrounding natural places like green spaces and blue spaces, also the built environment, the traffic infrastructure, and last but not least, also the environmental stressors of air pollution and noise. Well, after having this data of the participants, we need to link the data from the population health service and the urban environmental exposures for each participant. And then at the end, the 6th step is to pull the data sets from all the 4 study areas. At the end, we expect to have all this information for 17,000 individuals. Well, then, based on these data sets, we have planned to do several analyses. We have divided them in 4 main groups, or main cross-section, let's say. First, we're gonna do some descriptives to analyze the distribution of the urban environmental exposures across different study areas, across people from different socioeconomic status, and etc. Next, we're gonna analyze the association between urban environmental exposures and the health outcomes under study. Following, we'll analyze the pathways from urban environment to health, doing some mediation analysis. And the last step will be to do the health impact assessment, estimating the population attributable risk factor. Well, it's always nice when we are talking about the projects to at least mention both the limitations and the strong points of the projects. In this case, is clear that we are based in cross-sectional data, and as it is common for epidemiological studies, it would be more informative to use longitudinal data, especially for the temporality of the association. This is a clear limitation. And then we have the exposure misclassification limitation, because we are estimating the exposures at household level, but maybe the exposures from the workplace of the subject would be more informative, or at least it may have an effect on their health as well. So it's a limitation. And finally, some variables from the population health service are self-reported data. So we have some level of uncertainty in relation to this as well. But of course we have, or at least we consider that we have many strong points as well. To start, we are using and combining both objective and subjective urban environmental factors. So this allows us to have a really nice picture, a complete picture of the urban environments of all the participants. Then we are combining population health service with HIS estimates, and this provides us with a large volume of information and a large sample size of the study, which is necessary for conducting a good epidemiological analysis. And also, I want to highlight that our final goal is to create urban environment indicators with health equity perspective. So at the end, we want to generate scientific evidence that can help policymakers and public health professionals to take actions and to actually improve the urban environment and the urban health. So yeah, this is our project, and thank you for your attention.
Thank you, Anhua. Very excellent showing this study, and I'm looking forward for the results. And this 17,000, that sounds quite a large amount of people, even despite its cross-sectional. I think for some indicators that works very well, especially if we go perception and etc. So it's not only that we need always longitudinal studies, we can also study many things with those cross-sectional, and you can always develop from cross-sectional longitudinal study in a way, because you have a long career ahead. But let's go now to Robin van Kastel. So, and let's see about ethnic discrimination, and especially in the healthcare context. So the floor is yours.
Hello, can you see my presentation?
Yes, can you also put the presentation mode?
Yes, okay, now it should be.
Now it's perfect.
Okay, super. Well, hello everyone. I will be conducting my presentation on ethnic discrimination in healthcare and how cultural competence of healthcare providers might prove to be able to reduce this ethnic discrimination and achieve health equality or even health equity. To me, it seems very relevant within the subject of urban health, because we see that they are very often overrepresented ethnic minorities in urban areas. Now, firstly, I'm Robin. I'm a PhD student within the EDISTOOLS project, and EDISTOOLS is a large interdisciplinary project researching ethnic discrimination in several societal domains, including the domain of education, the labor market, and real estate. And of course, me and my team, we investigated in the field of healthcare. Now, ethnic discrimination in healthcare, it is commonly known that ethnic minority patients or ethnic minorities in general receive a lower quality of care, specifically in two big domains, meaning that they have far worse health outcomes in several cases. For instance, they have a lower life expectancy, they suffer more from severe illnesses, and even during pregnancies, ethnic minorities show more problems regarding their pregnancy. This is commonly referred to as ethnic health disparities, which is also a global problem. But also, as a second dimension, we see that within medical interactions with, for instance, general healthcare providers or practitioners, the medical interactions are of lower quality with ethnic minorities, meaning that the provider communication and the patient-centeredness during consultations, for instance, is of a lower quality as well. General practitioners, physicians, for instance, show more verbal dominance. They are less friendly when communicating with ethnic minority patients, and they are less patient-centered or more doctor-centered, meaning that they, to a lesser extent, explore specific ideas or concerns of patients of an ethnic minority group. Now, a key element in these healthcare disparities or ethnic inequalities is the concept of provider bias. Now, healthcare providers have certain biases towards ethnic minority people in general, just like the general population. And these can be very explicit, like certain ethnocentric attitudes, but also more interestingly, I think, implicit biases, meaning that healthcare providers are not really aware that they hold certain grudges or stereotypes or prejudice against ethnic minorities. Now, we can clearly see this when we ask general practitioners or physicians to assess patients, and we see that they assess patients solely based on ethnicity as being less intelligent, less friendly, less educated, and the chances are that they are less likely to adhere to recommended therapy or don't even comply, meaning that, for instance, when a physician recommends certain medication or therapy, the physician, him or herself, think that minorities will be less likely to do so. Now, there is in the literature a central concept of cultural competence, which is an evidence-based approach already defined as a way to up the healthcare provider's ability to provide cultural sensitive care, meaning that they are more able to adapt and respect specific cultural differences. Now, cultural competence consists of intercultural knowledge, intercultural skills, and intercultural attitudes, which is also indicated by both healthcare providers and ethnic minority patients as being important or even crucial in delivering equal quality of care to ethnic minority patients. Now, within EDISTOOLS Health, we have launched several studies to try and analyze this. These are currently in the stage of analysis, so I will be able to give you some preliminary results, but not our complete interpretations or analysis. Now, the general goal of our study as EDISTOOLS Health was to try and observe and explain ethnic discrimination in healthcare. What is it? Why does it happen? Which underlying mechanisms are contributing to these inequalities and this discrimination? But of course, the ultimate goal to try and reduce ethnic health disparities or inequality. We try to focus on general practitioners or physicians' specific intercultural attitudes, intentions, and behavior in intercultural situations. And we did this by once again, launching two main studies. The first of which is an experimental quantitative study where we try to measure the effect of general practitioners' bias on ethnic inequality. And the second is a qualitative study where we explore the ability of physicians to provide cultural sensitive care and why it doesn't always happen. Now, more specifically, these two main studies. For the quantitative study, we have asked physicians to participate in online video recorded consultations with simulated patients being actually actors we provided with a script to go and consult a general practitioner. And of this pool of general practitioners, we have asked a small sample to also conduct an in-depth interview. Now, to be precise, we had a total of 100 GPs, general practitioners, participating in our video consultation study, leading to 200 consultations because each participant did 2 consultations. And of these 100 GPs, 20 of them also conducted an in-depth interview with us. Now, for the quantitative study, to try and elaborate, as I mentioned, each participant, each GP or physician conducted 2 video consultations, one with a Flemish patient, indicating the ethnic majority group here in Belgium, and the other consultation is held with a Flemish Moroccan simulated patient, indicating the ethnic minority group here in Belgium. And of course, we try to analyze if there were specific differences in healthcare behavior specifically. We had a plethora of outcome variables in the study. For instance, the medical decision-making of the physician. Was he or she showing more empathy, specific communication styles, more or less patient-centeredness, based again solely on ethnicity? And then we quantified or analyzed these consultations through an OSCE. An OSCE is an objective structured clinical examination, which is in essence just a very common way to try and analyze and code behavior in consultations. Furthermore, we asked our participants to fill in a follow-up survey where we tried to measure the influence of certain attitudes on intercultural behavior. We once again had some outcome variables, mainly the GP's assessment of patients, expected therapeutic adherence, compliance, and honesty, etc. But we also used already validated measures of attitudes towards ethnic minorities, mainly scales of ethnocentrism. But we also included other measures, for instance, cultural intelligence, to see if they had an effect on their behavior. Now, some, once again, preliminary results are the following. Regarding communication styles, we did not see any noticeable differences based on ethnicity. But regarding the medical decision-making, we did find some. We can say that minority patients are in fact treated differently, but a very important side note, we believe, is that there is a large influence of the specific case. This means that when ethnic minorities, in our study at least, were in a medical interaction with the general practitioner, they were treated worse in specific cases, meaning illnesses or displaying specific symptoms, but in other cases, they were treated better. So this is, I believe, very interesting for us to further explore. Now, regarding the qualitative study design, we try to explore healthcare providers' perspectives regarding the topic of diversity sensitive care or culturally sensitive care using these in-depth interviews. Diversity sensitive care, once again, or culturally sensitive care, is the ability to respond as a healthcare provider to specific questions, expectations, needs, values of patients, regardless of their cultural, religious, or origin differences. Of course, with the ultimate goal to try and accept and overcome these differences. To achieve this, we had 4 main research questions. The first one being, how do GPs themselves describe the concept of diversity sensitive care and how do they translate it into practice? But then again, we also try to explore what complicates the delivery of this type of healthcare, meaning what are the barriers healthcare providers are facing when trying to deliver diversity sensitive care, and also what strategies are they using to overcome these barriers? How can they be supported in this as well? Now, if you kind of read between the lines in this research, we actually are investigating GPs' intentions regarding cultural competence, cultural sensitive care. For instance, what are their limits of physicians? Where does it end? Where do they draw the line? And also, who is responsible for the delivery of diversity-sensitive care? Is it solely the physician's responsibility to continue to ask about certain cultural preferences, or is it expected of patients to try and elaborate on them themselves? Now, once again, some preliminary results are the following. We found some very obvious emerging themes being language and culture. This means that when general practitioners are faced with a patient that doesn't speak the same language or doesn't share the same culture and shows clear cultural differences, it is very difficult for them to continue and provide them with quality healthcare. All of this also in a framework or context of severe time pressure, because cultural sensitive care requires general practitioners to make more time for their patients, but they are living or working in a context of extreme time pressure. So that is also a very difficult barrier they are faced with. Now, to overcome these barriers, they have indicated, the GPs in our interviews, that a lot of emphasis is placed on intercultural knowledge and skills. If you know about specific cultural differences and values, and you're also able to communicate and overcome them, you are clearly one step ahead of others in achieving health equality or even equity. Now, mind you that intercultural knowledge and skills are also central components to the entire concept of cultural competence, once again indicating its importance. Now, finally, if we take all of this together, our quantitative study analyzing specific attitudes and behavior of healthcare providers and the qualitative study analyzing the intentions, we are ultimately trying to put these together and develop an online interactive e-learning tool for general practitioners and in a later stage healthcare providers in general, where we will be trying to provide them with the necessary means to become more culturally competent as an ongoing dynamic process of achieving more health equity and at least equality. But this online tool is still in a very first stage, so we will be continuing to develop this tool to try once again to achieve health equity. Now, if you have any questions regarding this, please feel free to contact me. And if you're looking forward, just like me, on our results, you can also continue to check the website of www.edistools.org. I thank you for your attention.
So thank you, Robin, for this. So Alexandra, or who will lead now the question round?
Hans, I would say you, and you can all switch on the cameras. Thank you.
Yes, in the chat there is a question to Robin, and that's about, do you also take gender bias into account?
As of now, we don't take gender bias into account because we are trying to focus solely on ethnicity. So we had two different kind of simulated patients, and they were both female. So there was a Flemish woman and a Flemish Moroccan woman as well. So we can really point out if ethnicity makes a difference on treatment and communication styles, etc. But it is a very interesting remark to make, because it is known that, for instance, female physicians are more empathetic towards ethnic minority patients. So that is already known, but regarding the patient bias, that is less my field at the moment, at least. But again, interesting, very interesting remark.
Mm-hmm.
Thank you.
Yeah, like there are different aspects to study with this gender. If you take a physician and a patient, and also different ethnicities, so there might be kind of larger difference between the gender, like.
Absolutely.
It's also, it comes from the culture, though the cultures are different. So So anybody else? So also the other attendees, you are welcome to ask the questions.
I do kind of have a question for Ainoa. Is it a possibility of you to also include ethnicity or race in your analysis? Because I saw you're taking into account a lot of socioeconomic and demographic variables, and I was wondering if ethnicity is maybe one of a possible addition.
Yeah, indeed, that's a very good question, and we thought about that, and indeed in the population health service, it's collected, that information, so we do have information on ethnicity. We need to see how this information is selected, because it may be an open-ended question, and it will depend on how comparable could be this information, but we do have that question on the survey, so it might be interesting indeed to include it in the analysis. Indeed.
Okay, thank you.
Yeah, just a comment. It has been taken into account, and also in our several analyses, we have focused also on eastern part of Estonia, and there, like the main Estonians are minority there, believe it or not. But after the Second World War, so all the people were brought from Soviet Union, and we have cities where 95% of people are non-Estonians. So in a way, this is also sometimes quite difficult to study the health questions there. And the integration has been really challenged, and in a way, there are similar areas, but in a way, very different ones.
Mm-hmm.
And often we can see that the information, they are lacking the information, like, because mostly it goes to kind of Estonians or Spanish people or Flemish people. But if you go to those non-main nationality and different ethnicities, so for them it's always very difficult to get the information.
Yeah, we kind of have the same thing, at least in Brussels, our capital. I think it's indeed like you say, 90% is an ethnic minority, but there is a new concept of super diversity in our multicultural society. So it's kind of hard to maintain our categories of ethnic minority and majority, because it's all intertwined at the moment. But yes, thank you.
Yeah, and also have heard that like in Brussels, difference in life expectancy can be almost up to 10 years if you take different areas, different social
drastic,
groups.
yeah, exactly.
So it's very drastic. It's the same urban area, but you know, the health differences can be extremely large.
Exactly, yeah.
But then, just also have a question for you. Do you plan a postal questionnaire, or how you will circulate this, and what kind of response rates you are expecting?
Sorry, that's also for me, right? The question?
Yeah. What kind of methods you're planning? Is it the postal or email questionnaire, or both, or combined? Or
no, it's actually some of the as I said, there are 4 study areas, so some of the surveys are already completed, they are done, and some of them, the last one is the one from the Basque Country actually, and it will be completed by June, July, probably summer. And all the surveys are conducted in person. So a person specialized in doing the questionnaires goes to the household and does the questionnaire in person. So we are expecting a very high response rate, but we have not the numbers yet. But as it is in-person questionnaire, we are expecting a high response rate. Also because they are official statistical activities, so they are used to have a really high response rate.
Okay. Then you're lucky.
So.
Yeah, then you're lucky. It's really great you always get better results if people are going there. Otherwise, people are getting less and less lazy, more and more lazy, and less eager to fill in.
Yeah, and especially in these kind of questions where they are pretty, as I presented, we are collecting a lot of data, so they are not questionnaires that you can be done in 5 minutes. So
yeah. Okay, so there are a lot of different aspects we can study, health aspects we can study in urban areas. But I think we have now got this link to this networking event. I don't know, let's maybe we should go there. I'm not sure.
If there are no other questions, I would invite everyone who is interested in to go to the networking event where we can continue our discussion. And thank you everyone for taking part in this event, and see you later.
Okay, see you. Thanks for organizing this.
Thank you. Bye-bye.